Good morning, everybody. I am Nina D'Angelo, Vice President for the O'Fallon Chamber of Commerce and Industries, and thank you for being with us this morning. It came to the attention of some of the executives of the chambers around the county that we were all kind of getting the same questions from our membership as far as COVID-19 vaccinations and businesses and how that's going to work and how that was developed and decided on and all that good stuff. So we decided to put together a League of Chambers event. Hopefully not the last one because we like to play in the sandbox together. Yay! Today we have a couple of housekeeping rules. Everybody, if you're on, please stay muted to kind of prevent some of that background noise that happens. Tony Matthews with Western St. Charles County Chamber, he's going to be monitoring the chat box. So if you have questions, please feel free to type those into the chat and he will get to those. Also, we will have an opportunity at the end, given time, for questions and answers as well. But as they come up in your mind, feel free to type those in the chat. So here we go. We're going to get started. All right, everybody. Dimitri Ciance Chapman was appointed director of the St. Charles County Department of Public Health on November 12th of 2019. Dimitri brings nearly 25 years of experience in patient care, teaching, and research to St. Charles County, having served most recently as Senior Director of a Center for Medicare and Medicaid Services programs to improve health quality at 24 hospitals in 7 states. He began his career with BJC Healthcare in St. Louis as a critical care nurse and as a research nurse and faculty member at St. Louis University, where he taught public health nursing. He then worked in Arizona and New Mexico as a commissioned lieutenant commander of the U.S. Public Health Service at medical facilities serving Native Americans. After serving as a house supervisor and emergency intensive care unit nurse at a hospital in Gallup, New Mexico, he was director of nursing services for the New Mexico Department of Health and executive director for the New Mexico Board of Nursing. Ciance Chapman has received numerous honors for nursing excellence and leadership and has been active in the National Council of State Boards of Nursing. Additionally, he served as the board of directors of the New Mexico Center for Nursing Excellence, as a volunteer nurse for St. Patrick's Partnership Heal Clinic in St. Louis, and as a volunteer public health nurse for St. Francis de Sales and Holy Family in St. Louis. Ciance Chapman has a Master's of Science in Nursing Research, a Master of Public Health, and a Bachelor of Science in Nursing from St. Louis University. He received an Associate of Science degree in nursing from Jewish Hospital College of Nursing and Allied Health, now Goldfarb Nursing of School of Nursing at Barnes Jewish College. We also have with us today Dr. James Toprano. Dr. James Toprano completed his undergraduate course at Indiana University, Bloomington, with a double BA in biology and chemistry. He graduated medical school from the University of Kentucky and also completed a Master of Health Administration. He completed his internal medicine residency at the University of Kentucky and completed his adult and pediatric allergy and immunology fellowship at St. Louis University. In 2005, he joined the faculty at the University of Kentucky College of Medicine in the departments of internal medicine and pediatrics. He later joined the faculty at St. Louis University and served as the director of the Allergy and Immunology Fellowship Training Program. He later entered private practice, seeing both adult and pediatric allergic and immunologic disorders. He has participated in multiple clinical trials and published several chapters in medical textbooks on allergic and immunologic disorders. Currently, he teaches immunology through Kaplan Medical Licensing and serves as an epidemiologist for the St. Charles County Department of Public Health. He is board certified by the American Board of Allergy and Immunology and is a fellow of the American Academy of Allergy, Asthma, and Immunology. So please help me in welcoming Dr. James Toprano and Dimitri Ciance Chapman. There we go.
All right, is everyone seeing my screen?
Oh yeah, but we see your desktop too.
Yeah.
There you go. Beautiful.
There you go.
All right. Hello, everyone. So I'm Dimitri, the Director of Public Health for St. Charles County. I'm going to do just a quick overview of the pandemic in St. Charles County, and then my colleague, Dr. James Temprano, will discuss vaccines in greater detail. You can enter any questions that you have in chat, and I think those are going to be curated and asked, and we'll answer them at the end of each presentation. I'm going to go through these kind of fast. I want to leave time for all your questions and anything else that you guys want to discuss. And thanks for being here. We want to get information out that's accurate. All right, so this is where we're at right now. We've had about 42,000 cases of COVID-19 in St. Charles County, 35,000 of those lab confirmed. The others are probable cases. People sometimes get confused about the term probable cases. That's not a guess that a case might happen. It is a definition of being symptomatic with COVID-19 symptoms and having a known exposure to somebody diagnosed with COVID-19 in the appropriate time frame. Many diseases that are investigated as communicable have a probable case definition. It's usually established by a public health authority like the World Health Organization or the CDC. We use the CDC's definition for probable case. We've had about 500 deaths. 426 of those are confirmed. We've looked at the death certificate or the medical record to see that COVID-19 was a contributing cause of the death. We are on a downward trend for cases, both confirmed and probable, and deaths. So you can see our blue line coming down. This is our age. This is our age distribution, the colorful columns over on the right of your screen. You can see back in July, the purple, those were our 20-somethings that had a huge spike, and that continued. And now it's our working age population that is testing positive for COVID. The 20-somethings are still on there, but it's mostly 30-somethings and 40-somethings that are testing positive for COVID now. I'll get to deaths later. I have another slide for that. So the blue line is our confirmed case rates per 100,000 population. The red, yellow, and green line are the risk levels as established by the Missouri Department of Health and Senior Services. So we've finally fallen below the extreme risk and the critical risk, and we're headed down to serious risk. This kind of shows the same data on the previous screen, but also our deaths and our positivity rates and our diagnostic tests per 100,000. These are all moving in the right direction, and we're testing enough folks, and our deaths are finally coming significantly down. There is a limitation to these particular data points, though. We sometimes don't get death data until weeks or even months after the death occurred. It's not unusual for us now to be getting deaths from January and December. So what we see as very low deaths right now might not be reality, and we won't know that for some weeks to come. This is our hospitalization rate for St. Charles County residents. I only get data from the major health systems, BJC, SSM, and Mercy. So hospitalized folks that are going to some other hospital system like St. Luke's or some other hospital, they will not be reflected here. But the majority of St. Charles County's residents that are hospitalized in one of those three major health systems for our region. And we're finally below 40 people being hospitalized on a given day. We peaked back in November and December with over 100, 120 people every day. This is our death data, and 83% of the deaths of St. Charles County residents have occurred in people who are 70 or older, and they don't account for a very high percentage of our actual cases. That just reflects that while no one in their 20s in our county has died of this disease, and they've had the most number of cases, that's the age group that overall has had the most diagnosed cases of COVID. The older people who get this are very, very vulnerable to it. And I try to drive this point home with everyone because most of the people you're encountering that have COVID are having very mild cases. But there is a segment of our population that when they get COVID, it is a very serious risk for them dying. We are seeing fewer deaths. Our peak was back in November, December, and the beginning of January. This is the sequential vaccination rollout. So Missouri's phased vaccination distribution plan. And Missouri's plan matches identically with what the CDC published and is the plan for the entire country. So I don't think they could have named it any worse than they did with its phases and its tiers, but they did. Anyway, phase 1A, those are the public-facing healthcare workers, and then residents of congregate living facilities like nursing homes. Phase 1 is open. I don't have a way of knowing exactly how many people in that phase have been vaccinated, but we estimate there are 500,000 people in this phase in the state of Missouri. Phase 1B, Tier 1, are those first responders and emergency services, non-patient facing public health personnel. In this phase, we estimate around 200,000 Missouri residents, and phase 1B tier 2, those are folks who are 65 and older or adults who have a comorbid condition that makes them more vulnerable to COVID-19. Those are the only phases that are open right now. We estimate that for a grand total of these phases in St. Charles County, there's about 165,000 residents, 2.9 million in the state for these phases. There's whispers about Tier 3 being opened up pretty soon, but nothing definitive from the state about that. The state decides when we move from one phase or one tier to the next. The way we're managing these phases and tier groups in St. Charles County is when 1A was open, we had people register with us, and then we vaccinated those folks. When the other phases opened up, we also opened up to those other phase and tiers. We opened up vaccine appointments to those people as well. Now we have a very large pool of people that are 1A, 1B, Tier 1, 1B, Tier 2, and we randomly select folks from our roster, our digital roster, for appointments. And the reason we use random selection is because it removes any human bias. One thing that we do is when we select one spouse, this is happening quite a bit frequently. So a 70-year-old woman gets selected and her spouse does not. We also make an appointment for that spouse so that households are getting vaccinated simultaneously. We also have caregivers of some of our older citizens that we vaccinate at the same time too. They meet the 1A criteria. So as I said, we're following the state's phase distribution plan. We only do vaccines by appointment. And we have an online registry. The state has opened up its own registry. We're going to be phasing into using that. But right now, to get on the registry for the county, just go to our website that's listed here, or call our hotline, and then that person who answers can register. We have a number of folks that either don't have computers or struggle with the online registry. They can just call our hotline number. So we get vaccines from the state. We don't have a lot of notice. Our cadence now should be 1,200 vaccines for 2 weeks, each of the 2 weeks, and then 1,400 vaccines for the next. That hasn't exactly worked out, but we're hoping that that cadence will continue. It looks likely that the Johnson & Johnson vaccine is going to become available. That should increase the total amount of vaccine in the nation. Right now, it's about 16 million doses, I think, that are going to all states. And that might change how much we're getting in the coming weeks. We've been doing most of our vaccines out of the family arena. As a mass vaccine clinic, yesterday we gave about 1,300 vaccines at that location. And we're getting a lot of support from our community partners and volunteers. And I just want to put the plug out there that if somebody wants to volunteer, they can call our hotline, and we'll get them hooked up with that. We do need a lot of people from the community to help with this endeavor. This is not a large department, but vaccinating the population is a massive endeavor. So anybody that wants to volunteer, please direct them to our hotline. So this is the Regency, and Regency includes the counties listed there, vaccination allotment. So the first column you see is the number of people who live in that jurisdiction, the percentage of the population for the region, and then we get a total of 4,000 doses for the region, and they are divided up based on the percentage of population. There is one change to this table. St. Louis County was removed from this list, even though they are in Regency, because that health department was the only health department in the state that was listed as a high throughput provider, and they get their vaccine through a separate allotment, the same allotment of vaccine that goes to the major health centers like BJC, SSM, Mercy. So the 4,000 weekly doses are divided into the remaining counties, and our allotment is 12 to 1,400. Of the vaccines that have been administered by the Department of Public Health in St. Charles County, this is their age distribution. The largest group are the 60 to 69 decile. These are the overall doses that have administered, first and second doses. So Missouri reports 1,084,000 doses being administered, and that's about 11% of the population who've gotten their first dose. In St. Charles County, 9.7% of our citizens have gotten their first dose, 38,000 folks. And the Department of Public Health has given 5,000. We've actually given more than that. We don't have the most recent data. We gave 1,300 yesterday. We're giving 900 today, and I think we gave 600 or 700 the day before yesterday. So that this 5,000 will increase quite a bit when our final numbers come in. So this is the same data, basically how much vaccine has been administered regionally, but pay attention to that column on the right, and it tells you what percentage of the population for our neighboring jurisdictions have been vaccinated. So we're at 9.7%. St. Louis County is at 11.1%, St. Louis City 8%, Lincoln 7%, and Warren County 6.8%. And these are vaccines that are administered from all vaccine providers. So that 9.7% for St. Charles County, that's not just from the Department of Public Health, that's from BJC, SSM, Mercy, anybody else who signed up to be a provider. Compass is administering quite a lot of vaccine in our county. They're giving over, I think, 2,000 vaccines this week as well. Let's talk about the COVID-19 variants. So anytime a virus has the opportunity to replicate itself, it also has the opportunity to mutate. A lot of those mutations are benign in terms of infectivity or the morbidity and mortality of the person infected with the virus. Some of them are not. A virus can change to be much more virulent, to be much more dangerous or deadly. The three big ones that we're watching in the world are the B.1.1.7 that was first noted in the United Kingdom, the B.1.351 first noticed in South Africa, and P.1, which was first noticed in Brazil. We don't know a lot about these variants yet. We don't know how widely they have spread. We don't know how the disease is caused by these variants differs very much. We don't know how these are going to respond to therapies, to vaccines, or the various types of testing coming out. These are where they're showing up in the United States. So Missouri has only had one person diagnosed with a variant, and it was the B.1.1.7. That's the one from England. However, there is more than one person in our state, and I'll get to why we know that. We're seeing a lot of the new P1 in New York. There's also a California variant. There are variants in most states at this point. So the B.1.1.7, it spreads more easily and quickly to others. It does have an increased risk of death versus the other variants, but that's very preliminary data. This was only observed back in December, so we need some more research there. And something that happens in the background that you guys don't know about is that the state monitors our sewers for COVID-19. And we recently started looking for genetic variants for the COVID vaccine, or for the COVID virus that we find in sewers. And we did find the B.1.1.7 variant in sewer shed of St. Charles County, specifically St. Peter's. So somebody came to St. Charles with this variant and had a poo, and we've picked that up. So we know that there are more people with B.1.1.7 than the one that has been diagnosed. All right. South African variant, we first picked this up in October of 2020. There's not as many cases of this one in the United States, only 46. And the Brazilian, the P1, only 5 so far. But we'll keep watching all of these. This one might impact our ability to recognize antibodies. So that means that if a person has antibodies to the COVID-19 virus, those antibodies might not recognize this particular variant. But again, only recently discovered, still needs lots of research to figure out what this variant means for humans. This is our website. This is our phone number. Anything that you need, our hotline is a great place to start, or our website. The website is obviously getting very full of information, and some people are having trouble finding stuff there. We're always looking at ways to make it more intuitive for the end users. If you need a quick answer, the hotline is the number to call. All right, let's stop here a little bit and answer questions before we move on to Dr. Temprano.
Okay, so I have a few questions that came up on the chat. There's not a nonprofit listed on the tiers. Is there any chance you could tell us where the nonprofits would fall into this, or how that's included in the tiers?
Nonprofits weren't specifically addressed in the tiers. So, but depending on the nature of the nonprofit, it might be, if it's a nonprofit organization like Volunteers in Medicine, they fall under phase 1A. They're patient-facing healthcare providers. If it's a nonprofit for beekeeping, the people in that nonprofit organization, they would fall as individuals into whatever tier they fit into based on their age or their health.
All right, we have someone that's trying to get their staff. They're federally in the 1A group, but they fall in the 1B group for Missouri, and they don't know if they should enroll individually, their staff should, or if there's a way to get they said they're working with Nick, but I don't know who Nick is, but sorry. So.
Nick Kohlberg is our incident commander, but he became a father this week. He's out this week. We are planning on doing some closed pods. Pod is a point of distribution with some organizations, but we don't have enough vaccine for that yet. That'll be down the road when the flow of vaccine is much more. But you can always work with Nick or reach out to me, and we can try to arrange a closed pod, or at least start planning it. I've been working with all of our school districts, and we already have closed pods planned for them, but we do not have the vaccine to actually have them yet. But we went ahead and made the plan so that when we get that vaccine, we can go into the schools and vaccinate everybody who works there. So if people qualify, I recommend that they register themselves individually, and whenever it's their turn, go ahead and get the vaccine. And then when we can get to organizations to do closed pods for them, then we will. But that's going to be farther down the road. So register individually, and you should probably register at more than one place. You can register on our site, the state's vaccine site. You can register there. And you can also register in neighboring jurisdictions on the healthcare systems, even if you're not a patient. If you're not a patient of Mercy, you can still register with Mercy or SSM or BJC. I recommend people register all those places and help those seniors or vulnerable people in your life who may struggle with registering at all those locations to do so as well.
Okay, everybody, we posted, I think Molly, she posted the hotline number for everybody in the chat. If you want to volunteer, you want to email Molly there, her email is in the chat. So, and I can post that. And then we did post the registering link for St. Charles County. If you want to register, the link, it's in the chat. I'm going to go through, there's about 5 new messages at the bottom, which give me just a second. Okay, another question was people who might be infected with a variant, can they also be asymptomatic with the original strain?
Can they have both the original strain and a variant? If so, yes. And yes, people can be asymptomatic with a variant or the original strain.
So we have a question from Boys and Girls Club of St. Charles County. Is nonprofit working with children, is there going to be higher on the tiers? Is that just, should they just individually keep that going?
They should individually And there is no language in the sequential vaccination rollout plan that would give a specific spot to Boys and Girls Club, for example. So register individually.
Okay, for the next tiers in the methodology, how are they gonna, I think you had mentioned that it was kind of, there wasn't any, so like wastewater workers versus food service workers, is it purely in order of when the person registers to get vaccinated or in the list, or is there gonna notify you depending on which service you're in?
So
Okay.
they should be registered, and those critical infrastructure workers, that tier, that's 1B tier 3, whenever that tier opens up and is not open yet. They can register now, but when that tier opens up, then we'll start pulling from that queue of folks and giving them appointments.
Okay. We've had a couple questions on registering in St. Charles County and St. Louis County or neighboring jurisdictions. Do we want to do both, or?
Yes, you can register in neighboring jurisdictions. St. Louis County is vaccinating folks that are not citizens of St. Louis County. Lincoln County is not vaccinating folks that are not citizens of Lincoln County. However, as the Missouri National Guard mass vax events are available, they'll reach out to anybody that they can. So it's still worth registering in those counties that aren't vaccinating non-citizens or non-residents of that county. Get your name on the list if you want a vaccine, is the point. So.
And then I think I have one more, and that's if you volunteer with the county, are you automatically going to receive the vaccine?
Yeah, anybody who volunteers at our clinic, one of our mass vax clinics, we vaccinate them if they want a vaccine.
I think I've went through all the questions. Again, everybody, that we've posted the hotline number, Molly's email, and the link to register with St. Charles County is all in the chat. So if you want to copy that down, you can. And we'll also post that as well for you guys, but it's in the chat right now.
All right, thank you, everyone. And I'll turn it over to Dr. Tim Brennan.
Okay, can everybody see my screen okay?
Yes.
Okay. So I'm just going to talk about the actual vaccine update. So just the vaccine itself. And so here you go. My first slide is not even on the vaccine, right? It's on baseball. So the weather this week made me think, oh, I can't wait for baseball to start. And then Nolan Arenado coming to St. Louis. I'm a huge Cardinals fan. God, what a godsend. I can't wait for the season to start. But what does baseball have to do with COVID vaccines? And so I coach a lot. I coach Little League baseball. And what does every Little League coach tell their kids to do? They say, keep your eye on the ball, no matter what, keep your eye on the ball. And with regards to vaccines, the ball here to me is hospitalization and death. And so when we go through these vaccines, and I'm going to kind of hit on it over and over again, focus on hospitalizations and death. And I think that's kind of the way out of this pandemic. So this is just one slide that kind of looks at hospitalizations, and just to kind of give you an idea of the context and why hospitalizations become important, particularly in the St. Louis area and with the hospitals here. Back in March, we had our first case. And then we had the stay-at-home order March 21st to 23rd, and the first deaths reported, and the governor issued a stay-at-home order on April 3rd. What you'll notice here is how steep this curve is. So this is the rapidity with which hospitalizations are occurring. So then when we see this kind of this steep slope, we start worrying, are we going to have problems with capacity? And we start reopening right here, and we start to see those that trajectory for hospitalization, that slope going down. And then St. Charles had lifted restrictions in the middle of June. Again, The slope is going down. And then we did see St. Louis County increase some restrictions in July, but there were rising case counts. And Dimitri had showed that actually on his slide, one of his slides on the case counts, where we saw many young individuals. And that's what most of these cases were here, were a lot of young individuals that didn't necessarily need to be hospitalized. And then again, as we get toward the winter, we see this steep slope. And then there's a safer at home order issued in St. Louis County. And then we have this Pfizer emergency use authorization. They were seeking approval for that November 20th. But kind of keep this in mind, this hospitalization theme and death theme. I'm going to switch gears a little bit, and we're going to talk about the immunology. So just a little bit of immunology. I teach immunology. I love immunology. This stuff gets me excited, but I know it doesn't excite everybody. But I think in order to have an understanding of vaccines and how they work and these mutations, we need to have a little bit of an understanding on the immunology behind this. And so this is a coronavirus. And on top of the coronavirus, we have these things called spike proteins. And these spike proteins are the way that the virus attaches to the cell and gets inside our cells. So all viruses live inside our cells. That's how they replicate. They use our own machinery to make more proteins. And the way they make proteins is through genetic instructions. And these genetic instructions for a virus is called mRNA. And we're going to come back to that when we start talking about the vaccines. So a virus enters the cell, it spits out its mRNA, the cell will make that mRNA into different viral proteins and then make more viruses so it can be released and go to and infect other cells. When we see these proteins, other cells kind of pick them up and we make antibody. And so this is a kind of a complicated process, but basically when we see these spike proteins, we have one cell tells other cells to make antibody against it. And these little upside down Y stick figures, that's how we represent antibody. Whenever we write like a cartoon like this and reference antibody, these upside down Y stick figures, this is what an antibody molecule is. Now, with antibodies, any antibody that we make, we have millions and millions of types of antibody. But the important thing about antibody is it's highly specific. It only binds to one thing. So an antibody against flu doesn't bind to coronavirus. An antibody against strep doesn't bind to flu. It doesn't bind to coronavirus. So these are very, very specific things. And that kind of brings me to the mutations. And so let's pretend this is one of those spike proteins, those molecules that are on top of that coronavirus that lets it get into a cell. And here's those little upside down Y stick figures, and these are our antibodies, these antibodies that are highly specific for that spike protein. And if we kind of just do like a little magnification and we look at that one area right here where the antibody binds the protein, it's a very specific process. So this is the bottom of the antibody here, this green part, and the blue part is the top of the spike protein. And so when antibody binds to whatever it's supposed to bind to, what it's specific for, we have a really tight binding between those two structures. And so if we see something that gets mutated, and this is with any kind of mutation, some mutations are small mutations. And here we have a little bit of a mutated spike protein. So let's say it looks like this instead of that house structure, it's kind of half of it. And so these antibodies still bind it, doesn't bind it quite as well as it bound the antibodies to the original spike protein, but it still binds it a little bit. And so maybe we get half binding, for instance. And so that would be a mutation that we might be seeing with some of these variants that we're seeing, where we still get some binding, but maybe it's not quite as good as it would otherwise be if it was the native protein. Some mutations, though, can be very significant. And those pre-made antibodies that we have don't bind to the new protein. And so those will be the variants, if we see any like that, which I don't think we really have so far, but if we do see any like that, those could become a problem where we would really need to make significant adjustments to the vaccine. And so we kind of talked a little bit about the variants already. I don't want to go into a lot more detail, but there's the B117 variant, which is the one from the United Kingdom. We're seeing a lot more here in the United States. The B1351, which is the South African variant, and we will come back to that with one of these vaccines. And then the P1, which is a Japanese variant, and we haven't seen as much of that here in the United States. But these are the three that you're going to hear about in the news the most. And then recently, Dimitri had already mentioned, there's the California variant too. That's becoming a news story more recently. So let's kind of look back at vaccines. And so the typical process timeline for making a vaccine. And so this is usually something that happens over about 10 years or so, or even more. We have this exploratory preclinical phase where we find the targets for whatever thing that we want to make a vaccine to, those targets, the things that we want to make antibody to. Remember, I mentioned the antibodies very, very specific. And that phase can take several years. And then we go to phase one, and phase one studies are the safety studies. Are they safe? Is this drug or vaccine or whatever we're looking at safe to use in humans? And then the phase two studies look at immunity. It's not real world scenario yet, it's in the lab. Do we see immune responses in the blood? And then phase three is real world. Does it look like it's effective, and does it continue to look safe? And then phase four studies are post-marketing. Those happen after it's already come to market. And those go on for many years after a drug's brought to market. And so we think about COVID vaccine. I mentioned that many vaccines take many years to develop, and the COVID vaccine was just around a year. And I think there's concern that, maybe we went too fast with that. But one of the things that I think is important to realize is that discovery phase. That discovery phase had been going on for many years for this kind of technology, these mRNA vaccines. And they've been looking at those for many years, not necessarily for COVID, but that technology. And then the way they were able to speed this up to make it faster was to overlap these phases. So we had phase one and phase two studies running at the same time, and phase two and phase three studies running at the same time. And not to mention, we had an enormous amount of funding for these trials, more than we've got the whole world working on this. It's not just one drug that's supported by one company. And so there's a lot of reasons why this was able to go at such a faster pace than normal. So I'm going to talk about two types of vaccines, the mRNA vaccines, which is the Pfizer and Moderna, and we'll also talk a little bit about the viral vector vaccines, which is the Johnson & Johnson, which you've probably heard about, and then an AstraZeneca one. Subunit protein vaccines are vaccines that we use for many other illnesses. They are in development now for COVID, but we will be looking more in the summer as far as when I think we'll have some results from some of those phase 3 studies. So the mRNA vaccines, as I mentioned on my immunology slide, this mRNA, when it's inside a cell from a virus, when a virus infects a cell, it uses the cell's own machinery to make proteins, to make viral proteins. So what we're doing with the mRNA vaccines is there's this nanoparticle, it's a lipid nanoparticle, and it just contains the mRNA for the spike protein, just that one protein. So the genetic instructions for the spike protein. It doesn't contain the genetic instructions for the whole virus. So you can't make viral particles from this vaccine. You only make little spike proteins. When those spike proteins are made by our cells and then secreted, then we make antibodies to those spike proteins because they're seen as foreign. So the first of these vaccines, the Moderna vaccine, is an mRNA vaccine. We give that 2 doses, 28 days apart. One of the really important things about all these vaccine studies that have been done is there's been a real push to make the sample, so the people that we study this in, look like our population. We want to make sure we have older individuals. We want to make sure we have patients from communities of color. We want to make sure that we have individuals with high-risk conditions, because these are going to be some of the targets, especially initially, for these vaccines. And so there was a real push to include these individuals. In many studies with drugs, we get otherwise healthy individuals to study the drugs in. But for this, because we know who COVID affects the most, there was an amazing push to get these studies to look like the population that we want to give it to. Now, one of the things that you'll find with all these studies that I review is that the primary endpoint is the number of confirmed cases. So did you have COVID at all? not severity, just did you have COVID? And whenever we make studies, when we design studies, we have to have one endpoint that we're looking at. And with that one endpoint that we look at, we can figure out, well, how much of an effect do I want to have with this treatment? And then I can decide that I can figure out with some calculations how many people I need in the study. And so that was the main endpoint. That is what the study was trying to prove, is number of confirmed cases after receiving the second dose of the vaccine. There was another endpoint we call a secondary endpoint, and they wanted to look at the prevention of severe COVID disease. And so after the first analysis, the vaccine was shown, this Moderna vaccine was shown to be 94.1% effective in preventing COVID. So any level of severity of COVID. And that's a very, very high number. That was very surprising when this data came out that it was that effective. And here we are. Let's keep our eye on the ball. The most important thing to me, my takeaway from this study, was that there were 30 total severe cases of COVID. There wasn't one in the vaccinated group. Over 30,000 people, not one in the vaccinated group. So the Pfizer study, this is 2 doses, 21 days apart. This had over 43,000 participants. And again, they wanted this to look like the population we're going to be using it in. So they came from diverse backgrounds. And their primary endpoint was how effective the vaccine was in preventing any COVID. And their final analysis found that it had an efficacy of 95% in preventing any cases of COVID. And then again, our eye on the ball, 9 severe cases in the placebo group and only 1 severe case in the vaccine group. So far, between these 2 studies, we've got about 75,000 subjects, and we have 1 severe case of COVID in the vaccine group. And that's, I think, quite amazing. So how about adverse effects? Because that's usually the next question that people have when they think about getting a new treatment is, what are the effects that can happen to me? And fortunately, we haven't seen a lot of serious effects. We do see pain and swelling and redness at the site. Those are pretty common. Chills, tiredness, headache, that can happen too. And that can be usually within a day or 2 days of receiving the vaccine. And it can last a day or two. And so those are the main adverse effects that we see, at least the common ones. And you've probably heard a lot about the allergic reaction risk. And I want to let you know that it is not a common thing. It's pretty rare. We see about 2 to 5 per million individuals vaccinated. Initially, the reports seemed to think that it was going to be a little higher than that. But the more recent data shows that it's closer to the vaccine risk that we see with other vaccines that we give, like influenza or pneumococcal vaccination. And the other thing is this almost always occurs within 30 minutes of vaccination. It does seem that people that have a history of either a severe reaction to a food, a medication, a stinging insect, latex, or an injectable therapy seem to have a little higher risk of having a reaction. And we typically have those patients wait 30 minutes after their vaccine. So the other 2 types of vaccines that we're going to talk about are the adenoviral vector vaccines. And so this is a very similar technology to the mRNA vaccines. What they use is an adenovirus. And so this is a different kind of virus. Adenovirus typically causes a common cold. And for adenovirus, this adenovirus is an inactivated adenovirus that's oftentimes a chimp adenovirus. So it actually doesn't even cause any kind of disease in humans. And so they have put that mRNA, the instructions for the spike protein, inside that virus and then give it to patients. And then that virus will attach to the human cell, spill out its mRNA, and then you get production of spike protein, just like you did with the mRNA virus. So a little bit different technology, but still quite similar. The first one is the AstraZeneca study, and they have a 2-dose regimen like the 2 mRNA vaccines that we talked about. Their primary endpoint was, again, preventing COVID 14 days or more after the second dose of vaccine. And the total efficacy in that study was 70%. So a little lower than what we've seen with the mRNA vaccines, but still quite good. And again, keeping our eye on the ball, no hospitalizations or severe cases of COVID in those treated with this vaccine. No serious safety events related to the vaccine. And importantly, this vaccine can be stored and transported and handled at normal refrigerated conditions for at least 6 months. One of the things that I didn't mention with those mRNA vaccines, but I'm sure you've probably read about in the news, is there are significant cold chain storage requirements for those vaccines, meaning those mRNA vaccines have to be kept at ultra low temperatures, which can make logistics challenging in getting that vaccine from the vial into somebody's arm, because there's lots of temperature regulations that you have to have kept in mind for storage and thawing and mixing. The Johnson & Johnson and Janssen vaccine is the one that's been in the news most recently. It's also an adenoviral vector vaccine. They had a phase 1 trial published in late July, and it showed protection in non-human primates, and they started their phase 3 trials in mid-September. Now, you've heard a lot about the single dose. The Johnson & Johnson is 1 dose, but I do want you to know that they're studying a 2-dose regimen too. So it's not just, right now what they're thinking is a single dose, but a 2-dose regimen is also being studied. This has over 43,000 participants, 34% over the age of 60, 41% with comorbidities that increase their risk for having severe COVID, and 44% are from the United States with again, a diverse makeup. And 41% are from Central and South America, and 15% from South Africa. And that, again, on the next slide, is going to become important when we think about those mutations with this vaccine. And so among all the participants in the 1-dose study for this, it showed a overall protection of 66% in preventing moderate to severe COVID at 28 days after the 1 dose. The onset of protection seemed to be as early as day 14. And the level of protection against moderate to severe COVID 28 days after the vaccine, after that 1 dose, was 72% in the United States, 66% in Latin America, and 57% in South Africa. Now, remember, we talked about that B1351 variant. 95% of the COVID cases in this study that occurred in South Africa were due to the B1351 variant. And so people still got infection. So it's still 43% in this study still had moderate to severe COVID infection, but no one had COVID-related hospitalization or death. So while they did see cases of COVID in South Africa with that variant, no one was hospitalized and no one died. So again, keep an eye on the ball with this. Adverse events with the Johnson & Johnson vaccine, fever in about 9%, but incredibly, serious adverse events were higher in the placebo group than they were with the Johnson & Johnson group. They didn't see any episodes of anaphylaxis or allergic reactions to the Johnson & Johnson vaccine. And they have filed for an EUA, and I believe it's supposed to have its initial review on Friday. And they think they're going to have product available to ship immediately following authorization. So I expect that to be soon. And then it's estimated to remain stable for 2 years at negative 20 degrees Celsius. And then 3 months for our temperatures 2 to 8 degrees Celsius. So again, easier storage conditions than we have with the mRNA vaccines. And that's all I've got on vaccines. And so if anybody has any questions, I'll be happy to try to answer them.
All right, well, it looks like we have about 4 questions right now that I can see from the chat. So hold on one second. Get everything. My screen changed. So we'll start with the last one. So what happens, what's your recommended if someone's from day 1 to get the first vaccine to day 2, they said does not get the vaccination within the 21 days apart. What's the greatest number of days between the first and second dose an individual can wait before the vaccine loses its effectiveness?
It's not really known. We still, the current the most recent recommendation was to still get the vaccine, but it's not been studied, so we don't know. So I would really try to get that vaccine at 28, right around 28 days. We certainly know there's some latitude with that, but yeah.
If a person is tested positive for COVID and has gotten better, how long should they wait, if at all, before getting the vaccine?
So it's up to them. The current recommendation is that they can defer vaccination for 90 days because they should be, have protection from their initial infection. But once you've recovered and you're outside your quarantine period, you can get the vaccine.
Next question would involve the patients that are pregnant. So pregnant patients are right now at high risk, but have they received the vaccine, and has that been followed? And is there any data measuring, what they're seeing, safety issues with that as well, crossing over to the baby?
Yeah, so the data so far has been very reassuring. They still recommend getting the vaccine, but we tell our patients to make sure they speak with their OB and make sure that it's okay with them. There could be some instances, maybe an obstetrician might not want them to get it. And so that's the current guidance, is for them to speak with their own healthcare provider.
Is there any long-term concerns with the mRNA targeting vaccine?
Right now, no. Not that we can, obviously this has not been studied for a long period of time. They're still looking at this, still accumulating data. But everything's been very reassuring. There was a recent report that looked at adverse effects from both of the vaccines that had came out past couple of weeks, and everything looked very reassuring.
Recommendations for vaccines is there a better choice for children versus adults? Is there any of that data being seen?
So the only vaccines, we have two vaccines that are available, the Moderna and the Pfizer, so that are currently available. I anticipate Johnson & Johnson will be soon. The Moderna vaccine is only for 18 and over, and the Pfizer is only for 16 and over. And so we don't have a vaccine right now that has any authorized use for individuals under the age of 16.
Okay.
And we'll have to wait and see what they say about the Johnson & Johnson.
Okay. What is the latest? Is there any information regarding the length of protection with the vaccine that's currently available? And is it going to be an annual vaccine similar to the flu vaccine?
Mm-hmm. Yeah, so I think it's a good question. I think the current guidance from the CDC is for 3 months of protection. And I think that they would like to have done longer, but there was a little bit of concern about the variants, not knowing how these vaccines are going to be with the variants. And so I think since everybody that has gotten the vaccine is still, just about everybody's everybody's really within their 90 days. I think they're kind of taking a little bit of a wait and see approach. And so right now they've said 90 days, but I think I wouldn't be surprised if it was extended further once they get more data with the variants.
If someone receives both doses of the vaccine, can they still be a carrier of COVID? And how is it possible that they can affect others that are not protected?
Yeah, so that's an interesting topic. There was some initial concern that we could still spread it because we see asymptomatic transmission if you've been vaccinated. Now, there's a study that was done in Israel where they vaccinated a large number of a very high number of their population, and they're seeing decreased transmission. And so the thinking is probably not. We don't know for sure. That's the honest answer. And that's why people who get vaccinated, we still ask them to, you should still do all the mitigation strategies right now. So the mask wearing, social distancing, things like that, until we have more data. But I can tell you that the data that's coming right now is reassuring. And for other infectious diseases, so measles, for instance, that's not something we really see that with. Typically you're vaccinated and, you're protected, and you shouldn't really be spreading the disease to others. And so I think that still waiting right now, kind of a wait and see approach, but the initial data I think is reassuring.
Well, then I think that's all the questions that we had in the chat.
Great,
So I
great.
want to thank our presenters. It was some great information. So
Yeah, so I also would like to thank Dimitri and Dr. Taprano for your information. Thanks to everybody who logged in to get this information. If you guys, business owners, come up with other questions after this, you can funnel them through us. You can go to the website to see if you can find the answer there. Either way, and we'll be happy to help get you the answers that you need. So everybody stay healthy, stay safe, and we'll see you at the next League of Chamber events. Thanks.
hi, thanks guys.